Welcome everybody. Very pleased to have you here tonight. Particularly pleased that we've got our speaker here tonight because she's been multitasking as well as doing multidisciplinary activities. She multitasks, and she's combining tonight's session with her elder son's parents' evening. Fortunately, as I said, she made it back into home at night, although I suspect parents' evenings these days take place on the internet the same way as Jewish Medical Association groups. It's a particular pleasure to welcome Jo. She is, of course, a past London chair of the association, and she's also been active in many of its activities over many years. And she's going to talk to us about the experiences that she's had during the current period, not actually treating COVID-19 probably, but having to deal with the other aspects of medical care that are so important and that are looming very large in public awareness now as we're in the second wave, and people being aware of what they've missed, what they were getting back to, and what a backlog there is in the system. So look forward to hearing, and I'll hand you over to Jo.
Thank you very much. It's always very strange to be doing these talks because I feel like I'm talking to myself and so on, but I have prepared some slides which I'm hoping I'm going to be able to share. So I did have a little practice before, so hopefully we're going to get going with this. So can you see the slides? It should come up as a slideshow. Now, can you see the slides? I can see some nodding from David, who's the only other person I can see. So hopefully that's going to work well. So I am going to talk a little bit about what happened for breast patients during COVID. And I'm doing that both as a breast and oncoplastic surgeon, but also because I had a role within one of the breast cancer hubs to try and make sure that we could keep services going. So I'm going to give a little bit of an overview of what happened and some of the decision making that went on and how we manage things. And hopefully that will then create some questions which I'm very happy to take. So the immediate effects of the first wave of COVID were that we saw an 80% fall in 2-week referrals. So at the beginning, when we were just trying to sort out our capacity and work out how we were going to safely look after patients, we had a little bit of a breathing space for a week, which was actually quite nice as we tried to work out what we were going to do with the patients that we already had in the pathway. But it soon became clear that we were going to have difficulties in the future because patients were sitting at home with what we thought were likely to be very significant symptoms. And we're now starting to see some of the aftermath of that, as I'm sure everybody is seeing within their clinical practice. The National Health Service breast screening programme stopped screening except high-risk patients, which they did continue with. So MRI screening for the family history patients and the BRCA and affiliated mutations did continue, but everything else stopped, and there has been some publicity around that. I think one of the things to say is that crisis can drive change, and sometimes that can actually on reflection be very good. So it meant that we needed to suddenly redesign our breast pathway, and the thing that was very nice to see was that it was very clinically led. So very often redesign of pathway, as clinicians we can be quite frustrated because it may not feel as if it's clinician dominated, but it really did feel that, which was good to see. And it was clinically led across different geographical areas and different sites, but with multidisciplinary input. And breast is very good at multidisciplinary input. So we had input from ourselves, our oncology colleagues, and radiology. But our biggest problem was much the same as everybody else's. We had limited safety evidence. So we were trying to balance capacity, and we didn't really understand what capacity was going to mean. And but most importantly, we needed to think about safety. And there were all sorts of things that people started to share in terms of what they had seen, and particularly from the surgical point of view, whether it was going to be safe to operate on patients, and how we were going to make sure that the patients remained safe and COVID-free, how we were going to remain safe and COVID-free, and whether we were going to have capacity, and whether that would be pulled out from under us at short notice, because what we were very anxious about was about anaesthetic staff, whether they would be available. We were lucky, as I think most areas were, that we had national guidelines, and they came from the Royal College of Surgeons, as well as the Association of Breast Surgeons, which helped us to framework our prioritization. So although we had this drop in 2-week wait referrals, we still had them coming through, and we needed to divide people into high risk, low risk, and no cancer risk. So clearly high risk patients we still wanted to see. So we were thinking about patients' age and presenting symptoms. And no cancer risk, I think really those were the young patients with breast pain, where there is always a number of these patients that come through the 2-week referrals, and I think that it might change a little bit in the long run how we manage these patients moving forwards. And then in terms of surgical priority, we need to prioritize patients into 4. So those that were needing life-saving surgery. So for breast, there is very little life-saving surgery that needs to be done immediately. Infection, very significant infection can be one. And if someone were to have a massive breast bleed, which you usually only see after either surgery, which wasn't really going on, or some complex biopsying, you occasionally have to take a patient to theatre as an emergency. The patients we were really concentrating on were trying to divide them into 2, 3, and 4 for breast. So we were thinking about those that were time critical for cure, so that if we delayed their pathway by more than 4 weeks, that we would actually be affecting their outcome in the long run. And for those, we're thinking about the biology of the disease. So we're thinking about our triple negative breast cancers. For example, those that had already finished their chemotherapy, we would be expecting to operate within a window of about 3 to 5 weeks after their chemotherapy had finished. So if we extended that, that could be time critical for their outcome in the long run. Category 3 were those where we didn't predict that there would be a negative outcome with a delay. So those are patients who, if we delayed their surgery by 3 months, we did not feel that it would affect their overall outcome. So a good example of that may be a low-grade ER positive cancer that had been picked up, say, on a screening mammogram, impalpable, whether if we delayed that surgery, it would affect their outcome. And then, of course, we had our elective surgery, and that was quite easy to delay, because that's things like our breast reductions, our symmetrizing surgery, nipple reconstruction, removal of ports, exchange of implants, all of those could very easily be put on hold. So it was really finding a way to make sure that initially the category 2 patients, and then once we had more security about our pathways, the category 3 patients, how we were going to manage those, and was there anything that we could do to mitigate any negative outcomes if there was a delay? How were we going to change their pathway? The framework was really individualized. So we were looking at each case on a case-by-case merit, and what we did was worked as a hub. So and I'll show you the hubs, how they worked, but the hospitals that were involved in the hubs, we had regular meetings, much like this type of meeting, where we would discuss individual cases and prioritize them to make sure that we were putting those forward for surgery that really did need to go through time critical surgery, and thinking about other options for patients that didn't. So if we go back to a patient with a small low-grade ER positive cancer, for those that were postmenopausal, we could start them on some endocrine treatment, thereby starting their treatment. And although we would ideally want to be operating under the circumstances before COVID, we would have operated, we felt that we could manage them with endocrine treatment. We really had to balance the known cancer risk, or what we perceive to be the known cancer risk for each individual person, with unknown COVID risks. That was really difficult to start with. I'm sure everyone will recall how difficult it was in the beginning, because we didn't know if our so-called green pathway or COVID-free pathway, it went through so many different names, was safe. And that took some time for us to be able to feel confident with, and how we were going to keep our COVID-free patients from those who were at risk of having COVID. And we worked very hard to think about treatment based on biology. Breast cancers are now very well assessed, and so we were able to understand quite a lot about what treatments we thought patients would be suitable for. And we were still staging cancers throughout this, and for those that had been diagnosed beforehand, we knew their stage, so we could think a little bit about that while we prioritized all the patients across the sector to make sure that they were getting the treatments that they needed. So for Pan-London, we had 4 cancer hubs, and they were headlined by, we had 3 cancer hubs, and they were headlined by different hospitals. So Northwest and Southwest was under the banner of the Royal Marsden. North Central and North East was under UCLH, and Guy's and St Thomas's were the southwest of London. And all of these hubs had support very quickly from the independent providers. So the Marsden were operating on site because they were considered to be a COVID green site, as well as using the Cromwell Hospital. North Central and North East, we were based at the Wellington Hospital, and Guy's and St Thomas's were based at London Bridge. So HCA had quite a lot of support for the 2 hubs, and in many ways that was where my role came in, because I chair the HCA Breast Board and I also work at UCLH. So I was there to make sure that we had smooth running of the pathway as much as possible, that we had equity of care across the pathways. I was also there to make sure that those patients who were booked for private care were able to get it, and they were prioritized along with the rest of the NHS patients. So everyone was prioritized in the same way at the same meeting, and operated, and the operating lists were shared appropriately. So we had our protected green sites, and the cancer hubs were aware of those, and we needed to make sure that there was efficiency and also maximal utilization of capacity. So we couldn't only think about breast, we needed to make sure that actually there was opportunity for all different cancer patients to be operated on. And in addition to that, the private sector was supporting some of the urgent vascular and cardiac surgery. We really wanted it to be transparent, and we needed a fair allocation of resources. So it was very important that Pan-London, everybody was prioritizing their patients in the same way, and that there was equity of treatment across London. I can't say that that was the same for across the country, because I really don't feel that it was. I received a number of calls from patients who were unable to get treatment in the same way as we had been able to organise ourselves. But all we could do was work within the guidelines that we had nationally and use the resources that we had. I think that we were very lucky that we had the support of the independent sector, and that we had an ability to move our service across quickly. Certainly speaking for patients that we looked after at the Wellington Hospital, we were able to move the breast radiologists into the private hospital, and also to provide nuclear medicine. So the patients were able to have exactly the same workup preoperatively and perioperatively that we would have provided in their base hospitals under normal times. And that, I think, is related to the facilities that were available at the hospitals that we could use. And we really needed to use standardized COVID-safe perioperative pathways. Like much of what went on during COVID, this changed every time I blinked to start with, and it was really difficult to keep up with it. We were not testing staff weekly at that point, but we were very strictly self-isolating patients. To begin with, we were self-isolating them only for a week beforehand, and then testing them 48 hours beforehand. But we ended up with about 20% of patients being asymptomatic but carrying COVID, so their operations had to be deferred at short notice, which meant it very difficult to put someone else into that operating slot. And when we moved the self-isolation to 2 weeks, that dropped it considerably. So we were only seeing 1 or 2% of patients then being COVID positive. So we were making a safer and more robust pathway, but we were also cancelling less patients at short notice, which allowed us to, keep our theatre utilisation as good as we could expect it to be. We did have some concerns about how we were going to make sure that we had an anaesthetic support, because whilst we had all our surgeons able to operate and we were able to provide assistance, anaesthetic support from base hospitals, which is what we had at the beginning, became more stretched. And I think, again, we were very lucky that within London there were a number of surgeons, of anaesthetists who were not attached to an NHS base, who were sort of working only privately, and they felt that they were able to support us with, that was their sort of COVID response, was to support the NHS lists that were going on. So looking at the figures from the North Central East London hub, which we mostly ran out of the Wellington, there were some cases that went through the Princess Grace. We did 477 time critical breast operations. We were able to run a maximum of 3 lists, 3 separate breast operating lists a day, 5 days a week. We were able to make sure that we had a on-call rota for patients to be able to go back to theatre if they needed to, so that we could manage all eventualities and all emergencies. We were able to operate on high-risk patients, so those that were felt to be anaesthetically high risk, and we were supported by being able to put patients electively into PACU and intensive care. We were able to operate on one pregnant lady who had a breast cancer, and that was done at the Portland, to make sure that we had gynecology support and obstetric support, as well as the breast facilities. And the under 18s were done at the Portland. So I certainly did one young girl during that time. And the Portland followed the same pathways for keeping patients COVID safe. One of the things that we did when we first started operating was we simplified our surgery. So we were offering breast conserving surgery, and we were offering mastectomy. but we stopped reconstruction for 8 weeks, and that was done across the country. It was part of the guidelines. It was a really difficult thing to do, but it was related specifically to patient safety and also capacity. Reconstructive surgery takes longer and it's more complicated. Your take back to theatre rate is understandably higher. And what we were trying to do was making sure that we were managing the cancer. So for many women, that was a very difficult, because some of them will have been preparing for their surgery for some time. They may have had chemotherapy prior to their operation, and they will have therefore had about 18 to 20 weeks where they've been thinking about their reconstruction, and they've been all prepped for it. And we needed to reverse that decision immediately and explain to them that they were going to get a simple mastectomy and would therefore be discharged flat on one side, or possibly both sides, depending on their presentation. And that we didn't know when reconstructions would be restarting. So therefore we didn't want to delay their surgery. Remember, these patients were already category 2, so we don't want a delay. And for some of them, by losing the skin envelope and not proceeding with an immediate reconstruction, it will limit their reconstructive possibilities in the future. So that's going to have very long-lasting effects. We only stopped within London for 8 weeks. Pan-London, we then met as a group, both the breast surgeons and the plastic surgeons, to see, once we had established our COVID-safe pathways and our capacity, whether we felt that we could restart reconstruction. We did this ahead of the rest of the country. We did it outside of the national guidelines at the time. So we needed to be very careful with that reintroduction. We put some caveats in that all patients should be discussed at an Oncoplastic MDT. By this point, most of us have become very au fait with Zoom and Teams, and were able to manage meetings. And we decided that the safest way to reintroduce this would be to start with the simpler operations first. So we started with implant-only reconstructions. We, across London, decided that it would be the same week that we would start, to maintain this equitable service that we had been trying to maintain all the way through. And that we would audit very carefully how we did it, and that we would only do this type of reconstruction if there was no other reconstructive option in the delayed setting later. So it was a very narrow group of patients that we restarted reconstruction on, and we met again by Zoom a few weeks later to see everyone's experience and make sure that we were able to continue with this with capacity. And then we started to bring autologous reconstructions back in. So the DEP reconstruction is a great reconstruction, but you're blocking your theatre for 8 to 10 hours, and we needed to be sure that we had capacity to be able to do that, as well as keep patients safe before we manage that. So we did manage to reintroduce all autologous reconstruction as well. So when I think a little bit about the outcome of this, I would say that we did develop our MDTs, and we did expand our MDTs so that we were working much more collegiately, both within our smaller hospital chains that are together, but also across London. And I think that one of the benefits of us all working out of one hospital was that everybody got to actually meet each other, and I'm optimistic that may improve collegiate working for the future across hospital trusts. certainly at the clinician level, which I think will be very, very useful. So that type of networking, I think, will be something to keep going for in the future. We were also able to show that we can manage MDTs and decision making across quite big groups using technology, which is something that had always been felt that we couldn't do very successfully before, and there'd been lots of blocks about how we were going to make all of that work. But as we've seen from all sorts of meetings and webinars that I'm sure every single one of us has been involved in some way or another, it is possible. So I'm hoping that also will make the breast services across certainly London more equitable. We had good use of skill mix with support from one hospital to another. So where techniques were being used in one hospital that were not yet being used in others, we were able to do a little bit of training as well. Many of you will recall from any breast surgery that you did, when we are operating on cancers that we can't feel, we always used to put wires in on the day, and now we've got closed systems, so we've got lots of different ones that we can use. I use most commonly mag seeds, but there's localizer and savvy scout, all sorts of different ones, and in fact we were able to help train each other to use these things across consultant groups and across hospitals, which was very pleasing to see. I think there's going to be a massive impact on training. David may want to comment on that later with his medical school hat on, because I think it's affected both the medical students, but it certainly affected the junior doctors as well, because the FY1s that were supposed to come on rotation didn't get any breast training. It was difficult in the beginning, particularly to enable the registrars and SHOs to come across to the private hospitals where the operating was going on. That was related to keeping our pathways COVID safe. The hospitals are not made to have large numbers of junior staff around. We needed to make sure that we were keeping people separate. And they're used to really consultant delivered care. We were also extremely keen to try and avoid complications and reoperating. So certainly a large amount of surgery was going on, which was consultant delivered. And I think that will have an impact on training for some individuals. But the biggest question that I'm sure most of us have in whichever part of medical practice we're in is, what will be the future impact on outcomes for our patients? So for us, it's about the cancer outcomes for the patients that we treated, for those that we used a different pathway, something where we had interruptions in their systemic treatment, or we did the operation slightly differently. So what will be the future impact on that? We don't know. I'm personally starting to see some patients coming through who were aware that they had a breast change during COVID, but felt unable to bring themselves forward. They either didn't feel that they could waste anybody's time. They were worried about being able to get hold of their GPs, although it was very clear that they would have been able to. They were worried about coming up to hospital should it be said that they needed to, and they felt that they may be wasting people's time. And in fact, very sadly, but probably quite predictably, it's the younger breast cancers that I'm seeing that. So those that tend to be the more aggressive cancers, and in patients who will have thought, actually I'm quite young and probably this is nothing, and I'll just wait a couple more cycles and see if it goes with my period and so on. So I've certainly seen 2 or 3 of those patients recently who are coming with much larger primary cancers than we would have expected, and are also node positive. And I think that is related to having had a delay in starting their journey, which has been made by themselves. We were running assessment clinics all the way through. We were biopsying patients all the way through. We were staging patients. In fact, it was quicker to stage a patient during the height of COVID than it is under normal circumstances, because all the routine scans had been cancelled. So it was actually quite easy to get appointments. I think we are doing much more on the phone with patients than we did before, some of which I think works very well because they don't need to come in to get their results. And so they're getting those results quicker. But I think, I'm not sure how many other people have this experience, but I think breaking bad news over the phone is incredibly difficult. You can't really pick up on some of the body language. You really have no idea who is there to support the patient at the time that you're making that call. And whilst they do say that they want to know and they don't want to come into the hospital, I find that to be very difficult. I don't know how everybody else has found that, but I think that's really tough actually for both the clinician and the patients. And I find that there are some patients who I have now done their assessment, broken the bad news, operated on, and given their post-operative results, and they've never seen my face because I'm in a mask all the time. And I think, again, it's really difficult to build a rapport with patients sometimes when you can't see their face properly and they can't see your face properly. So I think some of those challenges are still there. So that is a kind of whistle-stop tour of what happened for the breast service, with a particular slant to surgery, because that's my area of expertise. But there were very similar guidelines that came out for treating with systemic treatment. And certainly there were patients who, under normal circumstances, we may have given systemic treatment to first, who, especially in the beginning, had surgery first. And again, when we became more confident with regards to keeping people safe with chemotherapy, we started to go back towards our more regular pathways. We are currently using all of our pre-COVID pathways to treat patients. And at present, we have operating within our base hospitals, although it is slightly less than we had before. We have started doing some of the level 4 cases. So there's some symmetrization surgery that's going on. There's some basic implant surgery, such as removing ports and exchanges. And we've also started to do risk reducing surgery, which is time consuming in terms of theatre space and is not strictly cancer surgery, but clearly some patients who are on waiting risk reducing surgery will develop a breast cancer if we don't start to move them along their journey. So that's where we're up to. I'm going to stop sharing my screen because you don't really need to see my outcomes, and hopefully we can open the floor up to some questions or comments. David, I can't hear you. I don't know if everyone else can.
There we are. Thank you very much. And you can see why the BBC asked you to actually give a very, very brief version of this tour, because you've explained several features which have prompted questions along the pathway. First of all, you've partly answered the question. Liz Lightstone wanted to know about more advanced disease presentation. But also about how are the patients coping with delays? How are you following up the patients who are having delays, even if it's a low risk one? And what's your backlog figure now? How do you estimate the backlog figure now?
So we our backlog. So we are seeing patients who've had delays, but we didn't. They're not ones that we've delayed the pathway, they're the ones where they delayed the pathway themselves, so they presented late. And that is very difficult to deal with. Mostly my view is not to dwell too much on it, because we are where we are and we need to move forward. So I'm making them feel that they didn't pursue something when they should have done is not terribly helpful. So I tend to just say that we were open for business, and I'm sorry that they didn't come sooner. But this is the situation, and this is how we're going to move things forward now as quickly as possible in a sort of timely fashion. In terms of our backlog, certainly at UCLH, we have now operated, I think, on almost all the patients that we had put into category 3. The only reason that we may not be operating on them now is because the patients themselves are delaying. But those patients are all taking endocrine treatment, so they are on some treatment. When they had their initial biopsy done, we put a clip in, so should they get a complete imaging response, we will still be able to operate on them, and they're being closely monitored both clinically and on with imaging. I think that most trusts are also managing quite well with that. The risk reducing surgery, so those with the significant family history or a known mutation, are the ones that I'm now currently trying to date. So so those are the ones that are really worrying me the most, although they are still part of high risk screening, so they are having regular imaging. But I think certainly the Marsden, I understand, has had one risk reducing patient who has presented with a cancer in the interval.
Right, and what about those who are low risk and have been delayed? How are they coping, and how do you handle them during the period? I mean, do you speak to them? What happens to them?
Yes. So once they were diagnosed, we obviously discussed with them about their management options. Most of those patients will have been started on endocrine treatment. So whilst they weren't having surgery, they were on some treatment, which is helpful for them, I think. And it was really just keeping in regular contact with patients. Once patients have started some treatment, they felt more relaxed and less stressed about when their surgical date was. It took some convincing to actually persuade some patients to have an operation during COVID. So I think as we became more confident in how we could manage the pathway, then it became much easier to persuade them, because once you started to do a couple of hundred operations within your pathway and you've not got any complications, we had no COVID infections at all, then it becomes much easier to persuade people that they'll be safe to have their surgery. Some patients were very nervous about coming into the private sector, very anxious that the hospital would be able to manage any of their issues. But in fact, I operated on many patients who we electively sent to the PACU afterwards, and they all had a one-night stay and were discharged from essentially an ITU bed to home. So we had no extended lengths of stays and no complications. And of the 477 patients, I think, that we operated on, we had 2 urgent return to theatres overnight, which were all managed very well, but and it would be in keeping with what we would expect under normal times.
Right. Related to this, Tom Evans was asked about how the radiotherapy was managed and how relevant was radiotherapy during this period.
So, well, we were quite lucky in that the fast forward data was about to be published, and in fact that was brought forward. So for patients under very specific with very specific pathology, instead of doing 3 weeks of radiotherapy, so the 15 fractions, we were very safely able to do 5. So that freed up quite a lot of time on our radiotherapy machines. So from the perspective of the sector, we were able to give radiotherapy, but we used the new guidelines. They were hurriedly brought through. So they were supposed to be brought through within that sort of 3 or 4 month period, but it was brought through quicker than that, and that worked quite well. And some patients who would have been suitable for breast conserving surgery, but obviously would have needed radiotherapy afterwards, elected for a mastectomy, so to avoid radiotherapy, because they were nervous about coming into the hospital on a regular basis, even though we explained that it would actually be for 1 week rather than 3 weeks for the vast majority of them.
Right at the beginning, you mentioned the BRCA, that the BRCA ones continued. You didn't. Those were the ones that were continuing.
Yes, so within the National Health Service breast screening program, the vast majority of screening was stopped, but high risk screening continued. So very much as we prioritized our patients into categories as to when they were going to get their operations, so screening categorized which patients were going to be screened. So the high risk patients continued to be screened because they're the ones where they were more likely to find a significant breast cancer if there was going to be one, but also they tend to be younger and fitter patients, so there was less concern about bringing them up to the hospital.
There's a question from Victor Selwyn about repeat mammograms in people over the age of 70 with microvascularization for 20 years. What happens to those kinds of people?
So in terms of screening, the National Health Service breast screening program is now back up and running.
Yes.
There clearly will be some changes, just as there are for all of our practice, in that we are trying to keep our waiting rooms emptier and keeping patients further away from each other. And also the machinery needs to be cleaned, and between patients, which it was always cleaned, but it now needs more of a clean in order to keep them safe. So screening is back up and running. We had, for a short period of time, they said that they were going to stop the opt-in over the age of 70, but that's just recently been reversed. Clinicians were actually quite keen to continue with the over 70s opting in, because they tend to be a very motivated group of individuals, because they have to opt in to have it, which means that they want to, and they turn up for their screening, whereas the national those that are under that age, so the 50s to 70s, you don't always get such a large number of people turning up for their screening. What has stopped is that we were starting in some areas to screen people a little bit earlier, so there was a sort of from the age of 47, and that has stopped. So screening is now going to start at 50, as it had done previously, with an opt-in from 70. So patients who opt in will get their screening.
So that's patient demand for that.
Yeah.
Rather than...
Well, yes. You know, breast cancer goes up with age, so it's always seemed slightly unusual that we have a cutoff age, but we do. But you can opt in, and that is now again open.
Is there any strange explanation why I haven't heard a figure of 20% asymptomatic testing positive?
Well, it's just what we saw in our figures to start with, and it may be related to you know, a higher number of people within a geographical area that we were serving, but for a short period that's what we were getting in our patients. But once we extended to 2 weeks of strict self-isolation, we found that we had very few asymptomatics. But it was really frustrating for everyone. First of all, it was horrible to phone the patients and say, you know, the night before their surgery, I'm very sorry you can't have your surgery because you've got COVID, which obviously scared them terribly. But also it was then too late to fill that slot, because so we had fallow operating space, which really during the crisis was a disaster when we were trying to make ourselves extremely efficient. So we thought about all different options. You know, should we swab an extra patient just in case someone couldn't be operated on? I'm sure most of us have all now had multiple swabs. I'm personally swabbed every week by the hospital, and it's not very pleasant, but it was even more unpleasant at the beginning because they really tried to, it felt like they were trying to tickle the bottom of your brain through that nasal swab to start with. So we didn't really want to to put our patients through unnecessary swabbing. And it was, you know, at one point there were a shortage of the number of swabs available, so it became quite complicated. But once we made it for 2 weeks, we found that we were able to get most of our patients through and on the correct operating list.
And the other question relates to the question of training. I mean, Leora Harvard's raised the question that becoming experts in COVID-19 delivery in specialities, and pointing out that GPs are really quite savvy at the IT connections and those kinds of things. But the question is, she felt that to keep the sixth form work experience students and, you know, can be kept into general practice, they can't come to hospital. So you know, kind of our sixth form work experience people with one group going to be advantaged or disadvantaged when they're applying for medical school. And I'll stop there. There's more about trainees, but I'll stop there. I mean, you know, kind of, is that what happened in the hospitals, and what do you?
It's still a problem. I still can't get work experience people through at the moment, and we're actually finding it difficult. I mean, all of our, certainly at UCLH, I have to be swabbed every single week. So all the rest of the staff, all of the medical students that are joining us also have to be swabbed before they start the firm. So that is all proving to be quite complicated. We have had a number of medical students who have then tested positive, which has put everyone into a tailspin, including the medical students. So we're actually finding it really difficult just to get the students through the firm at the moment. And I have been, and we're also limiting the number of people that can come into the cancer centre in order to make sure that we have enough space between individuals. So for the moment, I'm not allowed to have any work experience in, and I keep just everyone, the people that I'm committed to, keep emailing me, and I keep just saying, I'm really sorry, I can't do it at the moment. So I'm hoping that, again, when we become more clear about how we're going to manage things, we are able to reinstate all of that. But I think it's going to be really difficult, from work experience to the medical student experience to our junior doctor experience. I think every single part at the moment is being challenged, and we're thinking about how we can deal with this. We have, in some areas, they are, when they're doing you know, video consultations, then the students are able to join that to see how things are progressing and how we're managing patients. Certainly we're having the medical students that are on the firm, they are joining on the MDT every week. But I don't think it's quite the same as being in a room with all of us, where they can actually just sit and ask us a question as we go along, because really they are just silent observers. So they're watching the MDT, but I'm not sure how beneficial that is in the way that it was before, where one of them would generally sit with us and then could ask us questions as we were going along. So I think it really is going to be difficult. I don't think that we should have a two-tier approach. So if we are able to get work experience and medical students working well within general practice and within other areas of the hospital, then we really need to try and get some uniformity with all of that.
Well, thank you. Can I carry on with that line, because the penultimate year, in other words, the ones from last year were obviously badly affected, but they ended in March. The penultimate year, how are they actually coping now that they're back at medical school? And is there any interruption of them activities now, other than the fact of the testing COVID-19, and as you say, the fact that they're doing much more things remotely? How are the people who are going to be possibly sitting their finals this coming May, June, how are they coping and interacting? Because well, I'll stop there again, because that's a big enough question on its own.
Yeah, I mean, I don't know how everybody else is finding it, but I think that they're struggling a little bit, actually. I think that they don't feel that they've had the experience of their predecessors. Whilst, as you say, they have become very au fait with COVID-19, I think that they do feel that they are missing out in other areas. So, and some of them have been very nervous to come into the hospital. And they're nervous for themselves, and they're nervous that they don't want to give the patients anything. So my clinics within the NHS are running alongside the oncology clinics. So we've got lots of patients who could potentially be neutropenic, and the students are feeling a little bit anxious about that. So I think it is going to affect things. I worry about who's going to look after me as I get older with all of these training issues that are going on. But at least now that surgery is back on site within the base hospitals, we can continue with the surgical training of the junior staff in a way that we weren't able to, and we are able to give exposure to the medical students who feel confident enough to be able to come into the hospital.
I was given this, nobody didn't know that this was going to come up tonight, as it were, in this conversation. But I was asked this morning, what did I think about the issue of students with experience of oncology, and they could come out with their only experience of oncology or of oncology surgery being breast, and just because of the events, or colorectal, just because of the events of the present time. Is that a problem that you recognize, or are they being trained in general principles more than before?
I think that they are getting some general principles training. I think there are still opportunities, but we are trying. I mean, some parts of the hospital they're limiting how many people can come into the building at any one time. So the patients have to take some degree of priority. We also obviously have to balance that with training as well, and it's the same with the operating theatre. It used to be that you could have 3 or 4 students in theatre at the same time, but at the moment we're limiting it to 2. So I think that they will get hopefully some very intensive experience when they get it, but there's not going to be as much opportunity. But they should get the principles and then hopefully be able to extrapolate it.
And you mentioned the question of training and trainees, and you mentioned the question of nursing. What about nursing trainees who you would normally have? Are you having other healthcare professionals doing their training as well, or is that also suffering?
Well, I haven't actually seen a trainee nurse for a while, so it sounds like it's suffering now that you mention it, because I've been focused a bit more. But I mean, normally we would expect to have trainee nurses as well with us. So we have seen less, certainly, but that's just my personal experience. I hope that, again, as we get more confident with being able to see safely larger numbers of patients, and also as I think we start to test more of the population, we might then be able to get more back to normal. So because we're testing all of our staff, but obviously all patients that come into outpatients are not tested at the moment, but it may be that we come to a point where we are able to test people and get results back more rapidly, which will make it easier for us to get back to similar numbers of people in all of our outpatients. At the moment, we really are limiting the number of people that are allowed into the building. People are not allowed to bring a relative or a supporter with them, which I think when you're facing really difficult diagnoses, recurrent disease, failure of treatment, that's really difficult to do on your own. Because you don't have the emotional support of having someone else in the room with you from your family or support body. But also patients don't hear everything that we have to say, which is understandable when you're getting difficult news. And so I think they really are suffering by not having that supporter with them.
Right. I think we've been through a number of questions that have been raised, and we've had a really expert overview of a complicated field where one's trying to maintain things and trying to develop new things at the same time, new ideas at the same time, facing challenges that we really didn't expect. And I want to thank you very much for having taken the time to do this for us in what is a very busy time. And I think we should release you to go and have some of your dinner now.
Thank you very much. It was always a pleasure to have some time with the association. So I'm hopeful that at some point we'll all manage to see each other again in person.
Right. Thank you.
Take care. Bye-bye.